Hi everyone, this is Kimo Takayesu here at Full Code, and I'd like to take you through a walkthrough of case number 2, a patient presenting with acute substernal chest pain for the past hour. This is a 49-year-old female who had acute onset of chest pain and now presented to triage with EMS complaining of ongoing chest pain. She's diaphoretic, pale appearing, and had unstable vital signs at triage, so she's been brought back to the resuscitation bay. On arrival, we want to place the patient on the monitor to get an initial set of vital signs. And what we can see here is that she has a positive shock index. She's tachycardic, hypotensive, and also is hypoxic and tachypnic. So the first thing I want to do in terms of stabilization is to place an IV, not that we know specifically what we're going to do with that IV, and I want to improve her oxygenation. So let's put her on a non-rebreather mask. When we do that, her SATs come up, but her vital signs otherwise don't change appreciably. And the next thing I'd want to do in any patient complaining of chest pain is obtain an ECG. And so with that, we can see here that she has a sinus rhythm. She has dramatic ST elevations in V2, V3, and that is consistent with an LAD occlusion. She's having an acute anterior wall ST elevation MI. Here you can also see a little bit of elevation in 1 and AVL, and so that would also mean that she could have a very proximal LAD lesion, if not possibly a left main lesion. Now, when we go back to the patient, knowing her diagnosis is likely ST elevation MI, we can gather a little bit more history. She's presenting with a classic presentation, which is crushing chest pain, acute in onset 1 hour ago. She has nausea, as many patients will complain of in acute coronary syndromes, and she is lightheaded, which would be consistent with her hypotension on arrival. She has shortness of breath, and previous to this, she had one episode of chest pain about 15 minutes duration about a week ago when she was at the gym. So that could mean that she has a stenotic lesion from an atheroma that is now ruptured and causing an in situ thrombosis leading to acute coronary occlusion. We look at her history. She has diabetes, hypertension. She's on medications for those. She has no known drug allergies and has no substance history. Family history, not particularly significant in this case, as we have an ECG demonstrating an acute ST elevation MI. So we want to proceed relatively quickly through the review of systems and exam, looking for any clues to point us in any other directions. Differential things we might think about would be an aortic dissection, dissecting back into one of the coronary arteries. Typically with an aortic dissection, however, it'll dissect into the right coronary artery, leading to an inferior wall MI. And oftentimes those ST elevations can be waxing and waning over the course of the patient's presentation. In this case, with an anterior wall distribution, it is less likely, although not impossible, for this to be an aortic dissection. So, focusing on cardiac, respiratory, and GI review of systems, we note that she has chest pain, shortness of breath, recent exercise intolerance. She has no respiratory symptoms such as coughing or wheezing to suggest a pulmonary process, and she has nausea but no other abdominal pain, vomiting, or such. It's important to note, though, that sometimes patients, especially those prone to atypical presentations such as diabetic patients, female patients, they can often have no chest pain or very little chest pain relative to nausea and sometimes vomiting. And so it's important to remember that atypical presentations of acute coronary syndrome may just be heralded with GI symptoms. In addition, I'd want to ask if there's any recent leg edema suggestive of a history of heart failure or a concern for DVT with unilateral swelling. On exam, any critically ill patient, we want to do the ABCs. She has no signs of issues with the airway, no signs of issues with breathing other than she is short of breath, but she has symmetric breath sounds and a normal chest rise. Circulation is consistent with her hypotension. She has thready peripheral pulses, slowed cap refill. Next, I'd want to look at her heart, lung, and abdominal exams. We note that she's tachycardic. There's no appreciable murmurs. On lung exam, she has RALs bilaterally consistent with pulmonary edema. and her abdomen is non-peritoneal. She has no tenderness and no distension. On extremity exam, there's no appreciable edema. And because she has RALS and we're concerned about acute congestive heart failure, I'll take a look at her neck. And indeed, she does have jugular venous distension to the angle of the jaw. This picture is consistent with cardiogenic shock, secondary to an anterior wall MI, and she has likely significant pulmonary edema leading to her hypoxia on arrival. Stabilization, we can consider giving her some fluids. I would start with a fluid bolus that is relatively small, if anything, because if she does have pulmonary edema and is in cardiogenic shock, fluids will rapidly cause decompensation if we give them in a large enough volume or too frequently. So 500 cc's is about the most that I would give initially. As we can see, that intervention doesn't do much for her heart rate or blood pressure. In terms of differential, we've already talked about this likely being an acute myocardial infarction. Other things in the differential are myocarditis, although less likely given her regional ST segments. I already mentioned that aortic dissection is a possibility, and we'll just put another one in here, pericarditis. It is very unlikely, and I would not want us to go down the pericarditis route with her at this point, but it's reasonable to consider and keep on the differential for now. Now, in terms of bedside tests, I'd want to obtain the ECG, which we've already done. And ultrasound here can be extremely helpful in rapidly narrowing the diagnosis. If we check her aorta, check her heart, and check her lungs, we'll gather a lot of information within minutes of arrival. And here we can see that her abdominal aorta is normal in caliber, which is reassuring. That doesn't tell us about her thoracic aorta, but it does give us a hint that at least she's not having a large dissection in the setting of a dilated aorta, at least in the descending aorta, that would be contributing to her presentation. Now, some folks will use a suprasternal view in order to look at the arch. In this case, we're going to go ahead and proceed with ultrasound of her heart, which shows no pericardial effusion, but a very severely depressed ejection fraction with anterior hypokinesis, consistent with an acute anterior wall MI. She has diffuse B lines on her lung ultrasound, consistent with pulmonary edema. And so now we can obtain some lab work. I'd want to get a basic set of chemistries, a type and screen in case she needs to go to the OR or to the cath lab, which I presume is going to be the next step. I'd want to get a calcium level, coagulation panel, CBC, and it's not necessary to really get, but BNP and troponin would be reasonable to get. Of note, we know that she's in heart failure, so a BNP is not going to really give us much more information. And a troponin, whether positive or negative, would still not help us too much because from an ECG standpoint, she's having an ST elevation MI. And it's important to note that early on in MI, the troponin level may not be elevated. Now, you can see here her bicarb is low. She's got an elevated glucose consistent with her known diabetes, likely some degree of stress response. Her lab work otherwise looks reassuring. Her coags are unremarkable. Her CBC is unremarkable. And her BNP and troponin are indeed elevated, consistent with the presentation of acute pulmonary edema secondary to cardiogenic shock. Now, in terms of interventions, we can proceed with starting to treat her with aspirin, by far the most important intervention we can do from a mortality standpoint. And we can start her on a heparin bolus and drip. Heparin is an anticoagulant that, in the case of her having an acute thrombosis, will help stabilize that thrombus and prevent it from completely occluding or propagating, if it is completely occluding, along the vessel. Now, if we perform both of those, we have initiated kind of her initial round of treatment for ST elevation MI, but there's a lot more that we need to think about. With her chest pain, I would avoid nitroglycerin at all costs. That will only drop her pressure and worsening her cardiogenic shock. In addition, I think it's important to think about stabilizing her from a vasopressor standpoint. Because she's having an ST elevation MI, I'd want to use norepinephrine as my pressor of choice. Epinephrine causes a lot of ectopy, which could lead to an R-on-T phenomenon causing VT or VF. And dopamine is less good in cardiogenic shock and acute coronary syndromes because it's associated with potential for dysrhythmia, namely atrial fibrillation with rapid ventricular response, which may cause worsening myocardial ischemia. Next up, I'd want to communicate with cardiology. The cardiologist is obviously concerned about the ECG, but is unable to take the patient to the cath lab. So that leaves the ball in our court. Now we have to manage her pharmacologically, and in that case, we will need to proceed with thrombolysis. So if we go back to interventions, we go back to cardiac. At this point in time, given that she's in ongoing cardiogenic shock despite initiation of vasopressors, which we can see hanging here, we're going to lyse her. Now, in the real world, before embarking on lysis, I'd want to have an informed consent discussion with the patient, talking about the 1 to 5% risk of causing hemorrhage and the 1% risk of death from the therapy. However, with an acute anterior wall ST elevation MI, the mortality risk is somewhere around 35 to 40%. And so the risk benefit is clearly in favor of an acute lytic intervention. So we will go ahead and perform that. At this point, we can go back and reevaluate the patient and kind of see where her chest pain is at. Now her chest pain has resolved. And at this point, I'd want to check another ECG. And we can see here that her ST segments have come down greater than 50%, and she now has a post-perfusion T-wave inversion in the injured myocardial tissue that would be consistent with a resolving acute thrombotic occlusion. So with her ST segments coming down greater than 50% and resolution of her chest pain, we can consider her successfully treated with thrombolysis for her acute anterior wall MI. Now, in terms of admission, we need to think about getting her to the ICU. But before I do so, because they're going to follow her with chest x-rays, I would just want to make sure that I get a baseline chest x-ray. Of course, she's still in pulmonary edema requiring supplemental oxygen, but this will serve as a baseline for the inpatient team to further monitor her and manage her. At this point, she's awake, breathing, and she's got a reasonable oxygen saturation. I would not intubate her at this point in time. She seems to be tolerating her pulmonary edema well, and so we can go ahead and admit her to the ICU with the diagnosis of myocardial infarction. Any other things that I want to do? I could wait and hang on and go back, but I think we're more or less done with the case, and we did just fine. So as with all full code cases, we provide you with an overall score, diagnosis, disposition, as well as a detailed discussion and a point-by-point review of all of the reasons that we did these different interventions, took the different aspects of history, physical exam, etc. And so we can review those individually. The detailed discussion takes you through an entire walkthrough of the case, including other things that you should be considering from a diagnostic and interventional standpoint. And we also provide, as usual, resources for further reading to expand your knowledge base.